Hello, my name's Tara Lamont from the Wessex Institute at Southampton University, and as a member of the HSRUK board, I'd like to welcome you to this session of our annual conference. So this session is our plenary on social care and lessons from systems and analysis across the UK. It's the third of 6 plenaries. We had 2 yesterday and there's one this afternoon on mental health. And I hope you've had a chance to dip into the amazing repository of content we have online, including abstracts, oral presentations that have been accepted and workshop sessions. It's the first time that we've held our annual conference virtually, and we're glad we've been able to reach an even bigger audience this way, to connect health and care decision makers to valuable service-facing research on the important issues of the day. I'd like to thank the Health Foundation and Nuffield Trust for their support for the network and for this conference. So today at this plenary, we've got 3 fantastic speakers covering different approaches of social care across the UK. Patrick Hall is going to be our first speaker. He's a social care policy researcher with a background in local government at the Health Service Management Centre at the University of Birmingham. He'll be taking a broad look at comparative systems, including actually across Europe as well as the UK. And he'll be followed by David Bell, who has a long and distinguished career in economics and labour relations at the University of Stirling, with a particular interest in long-term care, including work influencing policy at the Scottish Parliament. He'll talk about some of the trends in social care and bringing us right up to the moment with recent analysis on COVID data. And then a rather different perspective from our third speaker, Reena Devi at the University of Leeds, with a background on research in rehabilitation and older people, before shifting to current activity, which she's going to be talking about in quality improvement in care homes. She'll be talking about some of this work with lessons perhaps for other researchers making the transition from investigations in health to social care. So these 3 speakers have about 10 minutes and they'll introduce themselves, so the talks will follow on, and then there'll be a panel discussion. You'll have a chance to submit questions for that panel session at any point during the time that the speakers are talking. So just use the Q&A function you'll see here on the screen at the bottom of your taskbar. And the important thing is, as well as posing a question, you can indicate your support for questions that are already there by the kind of like button, and that makes them more likely to be answered. I'll be looking at the questions and we'll hopefully have a chance to air quite a few of them at the end. So just before our first speaker, just a few introductory words from me. So kind of what brings us here? I think I hardly need say that our attention's very much on social care at the moment, with the current coronavirus crisis highlighting some of the long-standing problems in terms of the fragility of provision, the kind of chronic underfunding, the unstable care home market, the issues in terms of workforce shortfalls, but also I think the coronavirus has illustrated some of the issues about the lack of parity with the NHS, perhaps seen in the kind of PPE provision question. And what we already know about its low policy salience. There are real issues about the profile and priority given to social care compared to the health service, and not forgetting the iceberg of the hidden work by unpaid and family carers. So we hope from this session to learn more about some of the commonalities and differences in different parts of the UK, and perhaps what the current crisis has revealed more starkly about some of the structural and long-standing problems. I hope too that we will identify some of the unanswered knowledge gaps. And since this is a conference for and with researchers, I just wanted to highlight that there has never been a better time really to do research in social care. And a number of funding bodies, I've just outlined some here, have both long-standing support for social care research, but also particular calls out for the moment at the moment on COVID recovery, social isolation, particular topics that we might be touching on today. And many of these funders offer broad support in terms of programs, but also sort of fellowships, grants, and other sort of infrastructure support. So I hope that we'll not only identify some of the knowledge gaps, but perhaps stimulate some of you to go out and put some really good research proposals in. So without more ado, I'll pass over to Patrick for the first talk of the day.
Tara, thank you so much. I'd like to just give a big thanks to HSRUK for offering me the opportunity to speak in today's session, especially Tara and Helen for their hard work behind the scenes, setting up this session in such a strange time. I've been asked to talk about social care in the UK and this perception of crisis which pervades thinking about the sector. I'm a fellow at the University of Birmingham's Health Services Management Centre. I'm also an associate at the University of Sheffield's Centre for International Research on Care, Labour and Inequalities, which is where my work is based, and the Sustainable Care Research Programme is based, which I'm going to talk about. I'm also lucky enough to be a beneficiary of a career development grant from the School for Social Care Research. So I'm very much privileged to be a recipient of some of that support that Tara was just talking about. So the Sustainable Care Programme is a multidisciplinary ESRC funded programme which explores how care arrangements currently seen to be in crisis in parts of the UK can be made sustainable and to deliver well-being outcomes across the board for different parts of the system. And you can see here an example of some of the work packages that are involved in the programme. The overarching objective of the programme is to advance understanding of sources of economic and social sustainability in care, particularly how well-being outcomes can be achieved for care users, their families, carers, and paid care workforce, and trying to balance well-being for all of those parts of the system. In order to better understand these factors that support sustainable care, our team's work has been comparing the care systems that have emerged in the past 20 years in the UK's 4 nations since the UK legislated to devolve powers in the fields of health and social care to these nations' parliaments. And over that period, we've seen increasing differences between these care systems. And I'll talk a little bit about that today and draw on some of our work packages research. But really what we're doing is trying to theorise about care systems, understanding the context of those systems and their operation in the UK and similar countries, describing and theorising about how these different approaches might impact people who have needs for care, their families, carers, the wider community, and social care and health services. And also the ways that this process is perceived by the policy communities which are part of shaping those systems. So to kind of state the obvious, the crisis and the perception of crisis is often kind of framed as a consequence of what we call the aging society, a phenomenon which is driven by the downward trends in fertility and mortality that have characterized the post-war era, driven by public health improvements alongside social changes associated with late modernity. And generally, both fertility and mortality rates have been declining in the UK, although immigration has mitigated the impact of the fall in fertility. The UK's older population is still projected to grow dramatically, as we can see from the ONS figures here. But why does this matter for social care services? Well, the relationship between ageing and disability is not straightforward, and there is expected to be some compression of disability rates which relate to healthier ageing. The number of disabled adults is still set to rise dramatically in the UK. And you can see here in this chart that as we get older, many of us struggle with the tasks of everyday living. And assistance with these tasks is at the centre of social care delivery, enabling independence and social engagement. Another development over recent decades is the change in family structure. So in recent decades, the UK, like many countries across the developed world, influenced by cultural and policy factors, have witnessed what's called a detraditionalization in the nature of family structures, roles and relationships. And there now exists a plurality of socially legitimate types of family: marriage, cohabiting families, single parenthood, divorced families, step families. And these families are increasingly diverse in size, makeup, geographical spread. And this has resulted in multi-generational, multi-locational families. A parallel trend to this move to a post-traditional family structure in the UK is the continual rise in female workforce participation over the past 50 years. While only 57% of working age women were in employment in 1975, by 2017, 78% of women were in formal employment. And this entry has had a profound impact on the division of labour outside of formal employment. So care labour, once performed almost exclusively in the family by women, has been partly or fully organised through external means, meaning the state, the market and communities have intervened, where the family is no longer the sole provider, although remains the main provider of care. So care is at the centre of the new social risks for citizens and states associated with the transition to post-industrial societies. As old care risks have unravelled, so for instance, the lack of participation of women in public life due to care, new risks have emerged, and states have responded in various different ways to these tensions, as have markets. They're both responding to the socialisation of care that we've seen in recent decades. And as a result, there have been various attempts to describe these care regimes, so policy responses to these social risks, which impact the experiences of people with needs for care and their carers. These are represented as a diamond or a triangle, which attempt to show the respective involvement of family, state, market and community in the delivery of care labour. A really influential approach to this has resulted in a bit of consensus around the types of care regimes which exist in Europe. So we can see here the Scandinavian model, which might be characterised by universal support based on care need, funded through taxation, primarily state planned and delivered with a limited role for community and market organisations. Family care model, which is characterised by limited state provision, an emphasis on extended family responsibility for care, where in the UK that responsibility is largely within the nuclear family, alongside significant roles for charities, and the market playing a much more significant role for wealthier families. The subsidiarity model, where services are planned according to the delivery of subsidiarity, so delivered at the most local level possible or at the smallest scale, with an emphasis on family responsibility, obviously with variations between countries, and a significant role for local organisations, intermediate organisations like clubs, faith organisations and so on. And the UK kind of sitting almost on its own outside of these typologies as a kind of a needs and means tested model, so targeted public support for those most in need and the poor, where the state plans but doesn't provide many services directly anymore. And this entails a growing role for market provision, and as we'll see, for self-funded care as well. So, that where I am. While the UK sits awkwardly in the middle of these European typologies, its devolved nations have diverged over the period of the last 2 decades. And this will form part of the work that I'm doing with Professor Catherine Needham for Policy Press, which hopefully will be published in the next couple of years, depending on what happens. But we describe using Pollitt's framework, which understands convergence. We use it to explore divergence in the devolved nations. So there are discourse differences, so some convergence around the concepts of outcomes, but there's a real stark difference in the way that the role of market mechanisms are discussed, and the use of terms like commissioning, market management being more common in England and generally avoided in Scotland. And we think that this kind of stems from what Keating and Kearney called divergent cognitive frames, so the way that these policy communities think about themselves. There's been a number of different kind of decisional differences. So obviously, in terms of spend, there's a big difference. Northern Ireland and Scotland have maintained per head spend over the period of austerity, whereas England has seen a really dramatic reduction in spend, which I know David's going to talk about. Other big differences in terms of policy and legislation: Scotland have introduced the policy of free personal care, and there are small differences in the other nations around the means and needs test, but there are a number of different approaches to integration, to worker registration, regulation, carers' rights, and so on. In practice, there are different cultures of social care in each of the nations, with a greater or lesser emphasis on formality versus informality, influences and approaches to social work, working between health and social care, and approaches to integration. Obviously, in Northern Ireland, there is an integrated system which predates the devolution settlements of the 1990s. And big differences in the functioning of the policy community in each of those nations. Importantly, there's a real difference in the closeness of the executive to the stakeholder community, with there being a different relationship between, say, the third sector and policymakers in Scotland, Northern Ireland, Wales, and England. And in terms of outcomes, it really depends. It differs on the group or organisation. It's hard to say that one nation does it best, despite a perception that Scotland may be ahead in terms of policy and legislation. The systems themselves actually appear to make a smaller impact than the broader context of ageing, economic change, family and community structure. But there remains across the board a great deal of unmet need. But the contemporary sense of crisis, I would argue, is driven by 2 parallel trends and events, which is firstly the massive reductions in public expenditure across the UK, but particularly in England, which have resulted in growing unmet need, a growth in the proportion of people paying for their own care, an impact on quality of care across the board, but important to note and celebrate good practice. And I know that Reena is going to be talking about improvement in social care, and there's some fantastic work that goes on within the sector, and it's important not to ignore that. But pressure across the board, pressure on unpaid carers, pressure on paid staff, service organisations, the NHS, and kind of a fragile system and market for social care. We outline this in an upcoming journal article for the Journal of Social Policy with John Glasby, Matt Bennett and Yanan Zhang from the University of Birmingham. So look out for that one. And the second part of this contemporary crisis is the policy paralysis, which I know David's going to talk a little bit about as well. But this paralysis comes about despite widespread agreement about increasing demand, the complexity and uncertainty that people face going into the system, the inadequacy of the system to protect people against catastrophic costs, and just the unacceptability of the situation. We've got an article coming up in the Journal for Research Policy and Planning with Martin Powell, which covers that too. And then, of course, we have COVID-19, where, I think, it's really confronted all of us, the stark differences between the health and social care systems and the ways in which we value the people who provide and receive the two different services. And that has had, a significant impact on the outcomes of this crisis, on deaths and on people and their families. So there's a good ADAS report which shows how actually this COVID-19 crisis has further impacted carer breakdown, the sustainability of the provider market, and further increased what we perceive to be unmet need in the system. So on that cheerful note, I'd just like to say thank you for having me. And if you're interested to hear some more about the research that we're doing at the University of Birmingham and at Sheffield, then please get in touch with me. Thanks. So I'm going to pass on to David now.
Okay. Thank you, Patrick. That was a great talk, and thank you to HSRUK for the opportunity to talk to everyone this morning. Greetings from the far north of Scotland. My name's David Bell. I've had a long interest in social care. This began when I was involved with the Scottish Government's Care Development Group, which was charged with assessing the viability of the introduction of free personal care as part of Scotland's social care policy in 2001. I've continued my interest in this topic, and I'm currently involved with the international assessment of the effects of coronavirus on the care home populations. This is being led from the LSE, and I'm currently working on the UK component, which means bringing together somewhat disparate data from the UK home nations, England, Scotland, Wales, and Northern Ireland. All of the material is being published online from across the world at the site ltccovid.org, and I would strongly recommend dipping into that site if you want to know what's going on in respect of care and coronavirus. Today, my talk will address two crises, one that has undermined the quality and quantity of care provision in the UK, but particularly in England for several decades, and the other one which has hit us completely unexpectedly, finding us mostly ill-prepared, and has wreaked a horrendous cost on the frail elderly round the world, many of whom were care home residents. I've relatively little time, so I can only give you the barest outline of the institutional structures that support social care in the UK. They have common historical roots, For example, local authorities across the UK are responsible for the delivery of social care. This dates back to the role of local parishes in providing relief to the destitute through the various poor laws across the UK. Although there's a historical thread running through the design of provision, structures have changed somewhat since the introduction of devolution, as Patrick has just said. Since its inception over the last 2 decades, governments in Scotland, Wales and Northern Ireland have become accountable for social care policy, and there has been some divergence. This slide gives a partial picture of this divergence. It also reflects the increasing desire, as Patrick has already mentioned, to integrate health and social care based on the realization that increased life expectancy has been accompanied by more chronic disease, long-term conditions and disabilities, particularly affecting older people. Thus, while local authorities in each of the home nations provide the main funding for social care, new institutional structures have developed to facilitate greater integration with the healthcare system. A key point, however, as Patrick has said, is that healthcare is provided free at the point of use through the National Health Service in all 4 nations, but social care provision is means tested. Those with assets of more than £28,500 in Scotland or £23,250 in England have to pay for the full costs of their care, less any allowance or benefits. Irrespective of where you are, a stay in a care home may incur catastrophic costs to household finances. This is seen as inequitable because it means that a person with cancer is probably penalised less financially by that disease than is a person who has dementia. Provision of benefits may come through the Department for Work and Pensions, which supports those with disabilities through cash payments. Its remit, as Patrick has also said, does not carry through to Northern Ireland, but the system is essentially identical there as well. Care provision comes through a mixture of private sector, third sector and local authority delivery. Local authorities have almost disappeared as providers and rather focus on commissioning services. Providers are reliant on care workers. The NHS employs 1.4 million people, but social care employs 1.6 million. 80% of the workforce are women. Social care workers are less well qualified than healthcare workers, and their working terms and conditions are much less favourable. We shall return to that. Get the right slide. A useful starting point for discussing the first crisis is the Royal Commission on Long-Term Care, which reported in 1999. Seeking to augment the supply of good quality social care, it made a number of recommendations. These are listed on this slide. Perhaps most contentious is that regarding personal care, bathing, showering, dressing, etc., that should be made free. And only Scotland has adopted this policy, again, as Patrick has said. Little progress has been made around ensuring individuals against catastrophic costs. Capital limits have even failed to take account of inflation. Direct payments have been introduced in various forms across the nations that allow greater flexibility in the design of care packages through the provision of cash or notional cash. Nursing care, which is generally provided by those with nursing qualifications, is now free across the UK. This is consistent with the notion that healthcare should be delivered free at the point of delivery, and all of the nations have now got some form of care commission which regulates care provision in the different countries. Again, I'm just adding a little bit of further to Patrick's points. England has had a glut of reviews, but complete political paralysis. It still has to deliver a coherent policy response to the Royal Commission. There have been many reviews. Walnut, Dilnut and Barker, to name but 3, they came up with plausible mechanisms for managing the distribution of care costs between the state and the individual. but the failure to establish a political consensus around this has meant that no progress has been made. Indeed, a quite plausible proposal for reform became a poisoned chalice in the hands of Theresa May. Her proposal to increase capital limits to £100,000 was dubbed a dementia tax by Labour and the media, and arguably cost her her majority in 2017. She promised a green paper to outline government proposals for the reform of social care in England. That green paper has never been delivered. Issues such as Brexit have clearly been deemed more important. The consequences of inaction. The lack of a green paper means that several of the problems that afflict social care provision in the UK, particularly in England, have not been addressed. Firstly, and most fundamentally, the issue of funding, both in terms of its absolute level and the division between the individual and the state, has not been fixed, and a decade of austerity has made the funding crisis substantially more severe. Secondly, there are problems with the structure of the care home market and whether it operates in the interests of care home clients. Thirdly, there is pain and ongoing crisis in social care staffing, which has been exacerbated by the lack of funding. And fourthly, in social care in the UK is not well served by the data available to those wishing to redesign its structure. So let's take a little look at these in turn. In terms of funding, the crisis in funding care has been extreme. In 2018-19, total expenditure on social care by councils in England was 22.2 billion. This was below its level in 2010-11. It also obviously does not reflect the increases in population and the changing demography over this period. These changes are largely due to the extreme squeeze on local authority funding during the period of austerity, when local authority funding was substantially cut and social care comprises a very significant proportion of local authority spending. Cuts in social care budgets were inevitable. And these cuts were not uniform because the formula used to allocate funding to local authorities changed, favouring some authorities which managed to increase their spending, while others, many more others, had to suffer a significant and very marked reduction in their spending on social care. The Competition Markets Authority checks whether markets genuinely support consumer interests. Confusingly, given that each nation operates its own inspection regime, the CMA has a UK-wide remit. Its examination of the care home market in 2017 suggested that consumer interests were not being well served by the industry. The system is confusing, choice, complaints, and contracts are all problematic. Not much is known about outcomes. And a further fundamental problem is that the sector is monopsonistic. I'll lapse into some economics jargon. Local authorities are what it means is that local authorities are the principal purchasers of care, and they have arguably driven prices down below cost. The danger of this is that further investment in forms of care that require bricks and mortar is being stifled at a time when demand is likely to rise rapidly. The British public has become much more familiar with the essential nature of the tasks, indeed I have, which care workers performed during the last few months. Yet the sector is not an attractive one to work in. Low pay is endemic, and in consequence, recruitment and retention are difficult. Care workers have been unable to organise collective representation in pay bargaining. Recently, the Scottish Government has in effect become a surrogate trade union by ensuring that social care workers are paid what's described as the real living wage in Scotland. There has also, as Patrick has alluded to, been a high dependency on migrant labour, and the UK Government has not made any concessions in its recently introduced immigration bill to recognise the importance of care workers from overseas as key supports both to the social care sector and indirectly to the health sector. Few care workers meet the new Tier 2 threshold of earning £25,600 per annum. Effective evidence-based policy requires good data. By comparison with the health sector, data on social care across the UK is meagre. This has been recognised by the UK Statistics Authority, which recently published critical reports on the lack of investment by the home nations in data and in analysis. It chided the government statistics agencies for their failure to collect useful information that would help drive policies. This has become clear in our efforts to comment on the effects of coronavirus on care homes. I've spent the last few days trying to make up a consistent database on UK care homes, but that's a really difficult task. It fails to match the aspirations of Jenny Burton, who's argued that at least we should have a minimum data set available on social care from which we can start to make plausible evidence-based policy. And so to the second crisis. The UK locked down for the coronavirus pandemic on March 23rd. In preparation for what appeared to be a massive challenge to the National Health Service, it sought to clear wards of people that no longer required medical intervention, but for whom suitable accommodation was not readily available. These people are described as delayed discharges. This slide shows how these varied in Scotland between July 2016 and April 2020. Similar patterns were followed, I think, in England. Number of bed days lost in the number of and the number of beds occupied fluctuated mildly up until March 2020, when they collapsed. In trying to protect the NHS, mainly elderly, vulnerable people were moved out to alternative settings. These included care homes. Not all of the people were tested. The consequence was a dramatic spike in care home deaths. This is how infection spread to care homes in Scotland between the beginning of April and June. Around 660 separate care homes in Scotland, which comprise just over 60% of the total care homes, had COVID infections. And then we had the deaths that followed that. Statisticians largely agree that comparisons of the fatal effects of COVID are difficult to draw from data which rely on medics' assessment of cause of death. Instead, the more accepted measure that we hear in the TV regularly is what's known as excess deaths, the difference between current deaths and the historical pattern of deaths. These are usually assessed on a week of the year basis because the regular seasonal pattern of deaths occurs, which peaks in the winter and reaches a low point in the summer. Comparison between excess deaths by week in 2020 for England and Wales on the one hand, and in Scotland on the other, is shown on this slide for hospitals, care homes, and deaths at home. The vertical scale shows the percentage change in deaths during 2020 compared with the historical average. It is immediately clear that though there was some increase in hospital deaths above the historical average from week 14 to week 19, these were dwarfed by the size of the increase in deaths in care homes, which in England and Wales was just short of 300% of the historical average. Scotland experienced a large rise in care home deaths above the historical average, but slightly less than that in England and Wales. Further, the slide shows a sharp increase in deaths at home, which has largely gone unremarked, but which we feel merits further investigation to determine what proportion of these deaths were domiciliary social care clients. These last three slides have been drawn from our report on UK long-term care on ltccovid.org. So where do we go from here? As Warren Buffett said, it's only when the tide goes out you find who's been swimming naked. The latest crisis has further exposed the social care in the UK system in the UK, which was already struggling to keep its head above water. Reform just has to come. We need a system that is fairer to those of modest means, whether funded by government or the private sector. We need to incentivise investment in accommodation solutions because demand for care is on an upward trajectory. We need to ring-fence research support for the ageing population. Older people are poorly served by research in the UK, although as Tara said, there's been somewhat of an increase recently, while the US has a very clear support structure through the National Institute on Aging. There is also a need for increased attention being given to the social care labour market. And since policy responsibilities exist within and between the four nations of the UK, there has to be a greater degree of intergovernmental cooperation in finding solutions. So that's my talk. Thank you very much. I'll hand over to Reena.
Good morning. Good morning. My name is Dr. Reena Devi. I'm a Senior Research Fellow at the University of Leeds. And in this part of the plenary session, I will be bringing us down to a micro level and focusing in on the research around different quality improvement strategies that can be used to enhance care in care homes. I will present why it's important that we focus on care homes and outline some of the evidence in this area where quality improvement has been carried out in this setting. I will then describe two different approaches. One is a quality improvement collaborative approach, and another is a model that we're using in Leeds called Niche Leeds. Care homes are a key and integral part of the health and social care system. There are different types of care homes for older people, care homes for people with learning disabilities, for those with mental health challenges. But today in this talk, I'm focusing only on care homes for older people. In England, there are 15,000 care homes which provide a home for 400,000 older people. And to put this number in perspective, this is 3 times the number of hospital beds in England. So we're talking about a very large population, and a population which is growing, with recent projections showing that this population is increasing at a rate of 138% over the next 15 years. And just to highlight how complex and high the needs are of this population, the average care home resident is living with multiple long-term conditions, takes on average 8 different types of medicines per day, and 80% of the people in care homes are living with a form of cognitive impairment. So when we start off to think about how to enhance quality in this setting, it's important to examine work that's already been done and learn what works well in this setting. We've carried out a scoping review to do this, and the way that we operationalize what quality improvement is quality improvement is an iterative change management process used to enhance any aspect of care. With that operational definition, we were able to include 65 studies in this review and closely examined these studies to look at what types of techniques and strategies are being used and applied in this setting, where are they working well, and what's suited to this context. Because the evidence to date is reported in very varied levels of detail, we're not yet able to make conclusive recommendations around this because the evidence isn't described in enough detail. So because the evidence at the moment is quite limited, it's really key and important that we learn from recent and current initiatives. On this slide, I present insights from 6 teams that have used an approach called Quality Improvement Collaboratives. This is an approach where locally key stakeholders will group together and form collaborations and work on iteratively improving quality and focus on any given topic that might be a priority in the area. For example, reducing falls or improving pressure ulcers. This is an approach applied widely in healthcare settings. And so and with these 6 teams that have applied this approach in care homes, it gives us a really important opportunity to have a look and examine closely how does this approach work in this setting, what works well, and what are some of the challenges. So from these 6 teams, we talked about this and highlighted what's working well and what are the challenges. And these are presented on this slide. And today I want to highlight 2 which were important across these projects. So the first is one which Patrick has already touched on, is really celebrating what care homes do well. So within these quality improvement collaborative, that there'll be external clinical and quality improvement experts which work with the home to look at how to improve quality of care. And as this is a sector that gets quite negative press and is very heavily regulated, it's important that we work on creating a safe and encouraging working environment. This was a shared experience across the 6 teams, and the way that a safe working environment was created was to really spend the time with the staff, work on recognising the staff for their really highly skilled expertise, their skills, rich knowledge and experience in this sector, use encouraging language and celebrating what they do well. A challenge across all the teams was that collecting data is difficult. David has touched on this. At the moment in England, we don't have a systematic care homes data set. And so what this meant was when we carry out any quality improvement project, we need to collect data to demonstrate whether the changes we're making is having an impact. This takes a lot of time, resource, and can be quite burdensome alongside trying to do the day job and a quality improvement side project. And with this, people taking part may lose interest. They think it's more work than they anticipated. So this is quite a challenge and needs to be taken into account when we design and develop approaches to enhance quality in this setting. Another approach is one that we're using in Leeds, and this is called Niche Leeds. Niche Leeds is a model that is an exact replica of the Dutch Living Lab model, and it's founded on a partnership between the University of Leeds, Leeds Care Association, and Leeds City Council. A key feature of this model is that researchers from the University of Leeds are embedded in the care home environment and spend time with staff, with residents and relatives to really understand what matters to them. We take this and then translate it into a research question, which we then use to look for evidence-based answers to these questions. So we'll search existing evidence and literature, and where we find appropriate and robust evidence, we will translate this into a format and language that is useful and helpful for the care home. So in this screen, in this slide, sorry, you'll see that I've the screenshots of the niche know-how. So we call these summaries niche know-hows, and we work with the care home to translate the evidence in these into practice. Where there's a lack of robust or appropriate evidence, we then work with the care home to develop projects that will produce the knowledge and evidence to address their questions. This work started in September 2018, and just to give you a flavour of some of the topics that we're working on at the moment are around dental and oral care, enhancing resident wellbeing through providing meaningful and engaging activities. We're looking at staff recruitment and retention, which David highlighted is a long-standing key challenge in this sector. We're also looking at staffing and quality and staffing relationships. And more recently, with the current pandemic situation, we've been working on addressing the questions from which care homes have around the pandemic. So identifying what their questions are and looking at what are the lessons learned from care homes that have already had an outbreak, and how can we be sharing the key lessons with care homes to help prepare and manage future outbreaks. And to conclude, when thinking about improving quality, it's safe to say that we can't make any assumptions that strategies that work well in healthcare settings can be applied into care homes without adaptation. So we really need to pay attention to the care home context and adapt strategies for that. We need to be careful with our language. Quality improvement is a phrase really well recognised and used in healthcare settings. However, when applied in care homes, recent feedback is that this is quite a negative phrase, and so we need to be careful about this. As researchers in research community, we need to work with care homes in partnership with them. And as I've described, the evidence in this field is currently lacking detail. So it's important that we continue to develop knowledge in this area and share this using reporting templates so that others can learn from what we've done and take that forward for future projects and work. And just to finish off, some questions for further research. There's potential for looking at how we might be able to embed more of a continuous improvement culture in care homes. What would that look like? How can that be achieved? So how could we go about achieving that? Also, recently with this pandemic situation, evidence is being shared, guidelines are being shared. This presents an opportunity for us to learn how is this being shared at pace and scale, what's working well, and can that be taken forward to thinking how we do things at scale in this sector. I'd just like to say thank you to HSRUK for the invitation to speak today, and I'd like to say thank you and acknowledge colleagues that I work with.
Thank you all for some great presentations. We've gone from the macro to the micro in a really interesting way, and I take from Reena's presentation that we can't just lift and shift what we know from health, and there's a question coming up actually about language, which we might address in a bit, but also the sort of what we know from the sort of natural experiment across the UK, which Patrick and David in different ways have brought up, those divergent frames, those divergent systems and responses. And I would also reflect that the kind of golden thread of research running through these three presentations, that David is perhaps too modest. We had a discussion at the plenaries yesterday about how research can influence policy, but I think his work is an example of how economic and other research he's been involved with has influenced policy on personal social care in Scotland. So it's great to see all these questions coming in. We won't have time to address them all, but the four of us plan to do a blog picking up some of these threads for further discussion. But let me just take, in fact, the two, I think, most supported questions linked together. So adult social care is the focus of this plenary, but we're not just talking about older people. There's a question too about people with learning disabilities. Patrick, do you want to reflect on that?
Yeah, I mean, it's something that we think about as a community of researchers often, is about the kind of the different ways in which we emphasize the groups in which social care systems are designed to support, or not designed in one way. But, and of course, you know, the support for working age adults has suffered over this period, and you know can be seen as part of this crisis that we're talking about. But local authorities have made disproportionate cuts to older people services in particular over this period. So if we're talking about unmet need, you know, increases in excess deaths due to COVID, you know, older people have disproportionately bared the brunt of some of these reductions, and that's not to say that you know, others haven't suffered within that period as well. And of course, I think, you know, the vital work that social care services provide for people with mental health problems, people with learning disabilities, people with physical disabilities, working age adults, you know, I think what we've got to do is, you know, promote this work across the board, and not kind of, you know, make these different groups vie off against each other. And I think actually we need to increase the visibility of all of these groups that need support from the system across the board in order to make the case for social care reform.
Great, thank you. There's another question. Reena, you touched on your presentation about the use of language being really important in your work with care homes, and perhaps in this question it talks about not assuming medical models. Would you like to touch on that?
Thank you for the question. It's a really important one, and one that I think we might take for granted until we actually start working with the care home. So in Niche Leeds, we work in really close partnership with the care staff, with residents, relatives, and management. So we hear what language is important, and how we can translate what we say as researchers into a language that's helpful and useful for people that are using this evidence. So I would, just responding to that question, I would emphasize that it's important to be working with and in really close partnership with the people that we're intending these models and whatever we're trying to sort of work on. I think it's the independent living expectations, but yeah, working with the people that who is it intended for, and work closely with them, and just to get the language right is really important. I think we make some assumptions as researchers, language that might be useful, but it's always really enlightening to hear what the people in the sector think of what we think is like okay language, and sometimes it's not. So, yeah.
And David, I wondered if you had any thoughts on the questions about both the economics of unpaid care. I don't know if you've done any work on that, but also a question further down around the different responses to the COVID crisis from different parts of the UK.
So yeah, we have done work on unpaid care, and we found typically that unpaid care to some extent substitutes for paid care. It's a difficult balance to strike, because I know that sometimes unpaid carers and paid carers can work together in harmony. But what we have found is that where unpaid carers are not present, it is more likely that people will receive social care, which means that in a sense the state is using the unpaid carers to support individuals needing social care. What was the other
Just
question?
about the different responses to the coronavirus from the devolved nations and different parts.
Well, yes, the, they started off quite in tune, it seems to me, but have become increasingly divergent. And because they were quite in tune doesn't mean that they were correct. And this issue about protecting the NHS, I think, will be picked on and research for years to come, because it looks like the NHS, this was difficult to predict, but it never actually got to the same kind of stretch that was happening in Northern Italy. Northern Italy was I guess the exemplar, but the consequence of moving people out, and there are always these people in hospital who are not there for medical needs, but are there because there's no suitable accommodation available. What happened in those few weeks? I don't think any of the countries really have got can be said to be have a clean sheet as far as that's concerned. Since then, you know, the patterns have changed a bit, and it does appear now that certainly Northern Ireland has very few deaths. Scotland is perhaps which has perhaps not relied so much on world-beating initiatives, and that has perhaps been a strength, as it seems to have done better, but not well. Certainly within Great Britain, the record on care home deaths is not good at all, and indeed, as I said in my talk, there's another agenda which hasn't been scratched, and that is about people who have died at home and where they had come from, and why, you know, what were the circumstances in I know it's morbid, but in which they died. But we have to learn from that.
No, that's very true. And on that rather somber note, we're slightly over and the questions are still rolling in. It's been a fantastic discussion, and I'd like to thank the three speakers for giving us such a stimulating talks, and to all of you for listening and for the great questions you've posed. We hope to follow up with a blog and do drop into other sessions of the HSRUK conference. So thank you and goodbye.